So we'll switch gear and talk about liver patient this time. And I call it analogous to the cardiac patient scheduled for non-cardiac surgery is liver patient scheduled for non-liver transplant surgery. I have no disclosures, and I will talk about how to evaluate and risk stratify these patients, and as well as how to optimize perioperative outcomes. And we'll start with a question. So this is a 46-year-old man who has no past medical history, more or less normal BMI with excellent functional capacity, scheduled for elective inguinal hernia repair, evaluated in the preoperative evaluation clinic. So his primary care provider actually decided to obtain liver chemistries as part of preoperative clearance, and ALT came back at almost 2 times upper limits of normal. So what would you do? You're going to proceed with surgery, refer to hepatologist for further evaluation, repeat testing, and send the whole panel of tests, or order a right upper quadrant ultrasound. So go ahead. Excellent. So proceed with surgery sounds like the most, and some people answered repeat testing. So let's see what we actually know. So this is a spectrum of liver disease that we'll try to cover. There is asymptomatic elevation of liver chemistries. There is acute hepatitis, chronic liver disease, cirrhosis, and acute liver failure. Routine preoperative assessment. So like for any patient, the history and physical are the most important things. So you want to pay attention to things like prior transfusions, tattoos, prior transfusions, particularly a while back, certain sexual behaviors, personal history of jaundice, etc., and then physical fatigue, pruritus, jaundice, pulmonary erythema. Those are the things you pay attention to. And if patient is healthy, just don't test. Don't test because that's what will happen. What if you test it anyways? And commonly we still do that. It is part of standard comprehensive metabolic panel is ALT, AST, ALK-Phos, alkaline phosphatase, total bilirubin, and albumin. And aminotransferases in non-selective sort of routine testing will be elevated only in 0.4%. ALT, though, interestingly, can also linearly increase with increase in BMI. Remember the patient I mentioned, his BMI was 26, so I mean, you're not going to expect it to be elevated. And further actions taken in this routine sort of cohort of patients is only 0.1%. So again, do not test. So you tested, right? So you decided, then you end up looking at this type of things. Hepatocellular injury, which is disproportionate elevation of ALT and AST. Cholestatic injury is disproportionate elevation of alkaline phosphatase as opposed to ALT and AST. Mixed pattern, both are elevated, and you can also see isolated hyperbilirubinemia. You can put it in a fancy what is called R ratio, which is actually a ratio of ratios. One in the numerator, you will see ALT over ALT upper limit of normal divided by the ratio of alkaline phosphatase over alkaline phosphatase upper level of normal. So if you like math, that's what you can do. You can, if R greater than 5, it's hepatocellular injury. If it's less than 2, it's cholestatic injury. And anything in between usually falls into the mixed pattern. So that's one of the ways to quantify this. So when you see ALT and AST elevation, you have to know what is normal, right? So the upper limits of normal I mentioned here. When you see borderline elevation, which is less than 2 times upper limits, mild elevation, which is up to 5 times, and moderate, severe, and massive, I put in a separate category. So in borderline and mild elevations, you still want to repeat and evaluate. However, if it's any higher than that, patient requires immediate evaluation. Something's going on. And usually you will pick it up again on history and physical and follow up postoperatively. So what's the problem? Why would you be concerned under those circumstances? So elevated chemistries, if it's a spurious finding, it's no problem. If patient has chronic hepatitis, which is usually mild, if patient is asymptomatic, it's no problem. However, if it's acute hepatitis in its early onset phase, operating on this patient may be a bad idea, and maybe that's where you picked pick that patient up. However, if it falls into the resolution of acute hepatitis, it's no problem. So it's only one circumstance when asymptomatic elevation can actually create potential problem. Thus, again, history and physical, if negative, just still don't test. In global population, though, like here, NHANES 3 study in 15,000 patients here, if ALT was elevated in this patient population, over time they tend to have higher mortality. But you see also it takes years. So somehow these patients still escape the attention and they may have underlying liver disease. And they do have increased mortality from liver disease. So your repeated testing, it's still elevated, so you believe something is going on. The first line, you test for viral hepatitis, alcoholic liver disease, non-alcoholic fatty liver disease, hemochromatosis, drug supplement injury. Once you run through that, that's negative, then only you can proceed to that. Or you can just have your friendly hepatologist order the same tests, basically. That's the typical workup. You can have alkaline phosphatase elevation, again, out of proportion, R index less than 2, right? Confirm, you first confirm, you can order ultrasound and evaluate for intrahepatic causes like primary biliary cirrhosis or primary sclerosing cholangitis. Total bilirubin elevation, you just fractionate, see if it's unconjugated versus conjugated, and then you just run down the list of your pathologies. So the few words, though, remember I mentioned that in patients with increase in BMI, you can have ALT elevation. So one of the things that is more and more attracting more and more attention in the hepatology world and the transplantation world actually is non-alcoholic fatty liver disease. It's getting close to becoming #1 cause actually for liver transplantation these days. It has bidirectional association with metabolic syndrome. It's excessive fat accumulation in liver parenchyma, and more importantly, not associated with other reasons for liver disease, like specifically no significant alcohol consumption. And it can vary just from pure fat accumulation in the liver to steatohepatitis, which is inflammation, or NASH, with progression to fibrosis, cirrhosis, and even now new entity, fatty liver-associated hepatocellular carcinoma. Role of screening for this pathology is actually unclear, and even in high-risk populations, and just provider has to be careful and remember that those things can happen. And you can use fibrosis score, fibrosis 4 calculators just to see, or transient elastography to identify patients who have more advanced fibrosis. So if you proceeded, if you did, let's say, right upper quarter ultrasound, you see patient may have early fibrotic changes, do the fibrosis score. Then liver biopsy can be done. There is nothing really to do other than losing weight, potentially bariatric surgery, and as I mentioned, in certain cases, liver transplantation. So these are the scores. I just mentioned them here. It's non-alcoholic fatty liver disease fibrosis score and the FIB-4 score. Both can be found online, and MD Calc is just one of the calculators that is out there. Okay, so different patient. So in the first patient, if such situation happened, I would probably just retest. Most likely it's just a spurious elevation and just proceed with surgery. Clinical scenario 2, 52-year-old woman this time with primary sclerosing cholangitis. Her MELD score calculated as 17, hospitalized, now scheduled for percutaneous biliary drainage due to recent episode of cholangitis. She reports chronic limited cutaneous bleeding, which self-limited, just as stated. Her hemoglobin is over 8, platelets are 48, INR is 1.8, PTT is 26, fibrinogen 174. She has no ascites, good renal function. Prior to procedure, what are you going to do? How are you going to correct coagulopathy? Platelets, give platelets and FFP, hold providing blood products, pre-procedure and transfusion is needed, or give platelets, FFP, cryoprecipitate, or tranexamic acid. Just make your choice. Excellent. So let's see. Platelets and FFP is the most common answer. And then holding products is the next common. Okay. So our friendly interventional radiologists, that's how they classify risk of bleeding. This is actually guidelines by the Society of Interventional Radiologists. And put their low risk, moderate risk, and high risk. High risk, the intervention that this woman is supposed to get would fall into category of a high risk. Put it as biliary intervention and creating a new tract in the liver. So what the Interventional Radiology Society actually says that for low risk, they recommend to correct coagulopathy with INR threshold of 2, platelet threshold of being of 50K. Moderate and high risk, INR threshold goes down to 1.5 and platelet threshold still stays at 50K. That's what the recommendation is. What happens with the liver? It's not as simple of an answer as you might want to hear. Because in liver, all the stages of coagulation pathway, they get rebalanced. And actually, these patients sometimes may have hypo and hypercoagulable state at the same time, but rebalanced to function right where they are. That's why your procoagulants and anticoagulants are rebalanced. That's the rebalanced state. And this is just to show what exactly happens. So, for example, in primary hemostasis, where it's a platelet vessel wall interaction, platelets go down. You all know that. However, their von Willebrand factor goes up. I actually make platelets more sticky. They actually work better. And same happens with blood coagulation pathway. Your procoagulants go down, which makes patients potentially to bleed, but so are anticoagulants. And so is actually factor VIII, which is produced by endothelium. So everything gets rebalanced. So even though they're numbers, so the numbers that you see is just largely a laboratory abnormality, more so than the true reflection of the hemostatic pathway. But more interestingly, what happens if you give platelets to patients, so the left graph here shows what happens to patients after you give unit of platelets. On the far left, you see a normal person, right? The platelets go down immediately after transfusion, and spleen accumulates those platelets. In people with hypersplenism or splenomegaly, platelets go down to where they started almost immediately. So their transfusion in these patients may be not doing much at the time of or as a prophylactic measure. Same happens with the correction of INR. The graph on the right shows you that to drive INR from 1.5, let's say that's the lower bound that the Society of Interventional Radiologists recommends, drive it down to where? To less than 1.5, you need progressively increasing number of units of FFP. So next thing, what happens, you get overload. Patients with cirrhosis, portal hypertension goes up, they actually can bleed more because of this. So better a potential approach is targeting hemostatic defects more precisely. There is actually no magic INR, with FFP never being the primary reversal agent. Bleeding screen for mucocutaneous bleeding, meaning active mucocutaneous bleeding. You just touch your gums and you keep bleeding. Not like self-limited bleeding. You have nosebleeds. You bleed from your mucosa elsewhere. So that's clinical risk factors for high-risk clinical events, which means is this patient also at risk for sepsis? Are they at risk for portal vein thrombosis, or have they had portal vein thrombosis? Because you know these patients may actually be intrinsically more hypercoagulable. Do they have acute renal, acute respiratory failure? Are they at risk for that? Because you're given more plasma, you can actually cause that. Evaluate for anemia, less than 7, hyperfibrinogenemia. Less than 100 is a good clinical threshold, and renal failure, because platelets may be dysfunctional because of that, not because of the liver disease. And consider really platelet transfusion if less than 50K on a case-by-case basis. So my approach in this patient would be no prophylactic transfusion, optimize renal status, which this patient has optimal, treat as needed if they really bleed. And there is data emerging actually that platelets number does not in itself predict need for blood product administration in this patient population. You avoid hypervolemia, avoid acidosis, avoid hypothermia, those things that exacerbate bleeding. And post-procedure, just excessive vigilance. And obviously, surgical hemostasis, or hold pressure for long enough after procedures. If you do bleed, viscoelastic tests seem to perform better than the classic tests of coagulation. Again, no role for prophylactic FFP, platelet transfusion considered to maintain the number greater than 50. Cryoprecipitate, again, depends who is talking. Sometimes the threshold is 100, sometimes it's 150. I generally, in the bleeding patient, try to keep it greater than 150. And surgical hemostasis is a must. All right, so we move on to a different pathology, right? So let's talk about, this is a 72-year-old woman with alcoholic cirrhosis. She has portal hypertension, has complications of that, hepatic hydrothorax, hepatic encephalopathy, varices. She does have ascites, though not currently, and she's not listed for transplant. There are reasons for that, but we're not discussing those. She does have osteomyelitis of the spine. She needs a large procedure, basically, a big spine surgical procedure. She does have mild COPD. She is also difficult to cross-match. Echo, I mentioned it here, EF is 65 to 70% pseudonormal, feeling RVSP relatively high, and prolonged QT. All of that is consistent that she may have underlying cirrhotic cardiomyopathy, right? Functional status, she gets dyspneic, and those are her medications. There's quite a few people actually in the United States who have liver disease, which amounts to 1.6%. Number of deaths is close to 40,000 of people die of liver disease in the United States. And what kind of liver disease? I'm just keep returning to the same initial framework. Asymptomatic disease, you do not send liver chemistries. You clearly don't operate on patients who have acute liver failure unless you're doing liver transplantation. Acute viral hepatitis, alcoholic hepatitis, or severe chronic hepatitis. Out of chronic liver disease, the safe ones are mild chronic hepatitis, the ones that are relatively asymptomatic. Non-alcoholic fatty liver disease, autoimmune hepatitis, hemochromatosis, Wilson's, they are safe. Cirrhosis, though, carries variable risk depending on severity. So that's the pathology we'll focus on during the last segment of this. So why cirrhosis?